Okay, first version of this didn't have sound, so we're gonna redo this guy. We're gonna talk a little bit about transmission pathways and EPI studies. I think that we briefly mentioned something about indirect and direct transmission, but I don't think we've really gone into how different pathogens transmit through different pathways. So I want to talk a little bit about a few of them, but I just want to mention or talk about, address how they're different have different implications for different types of ID studies. It has to be said that some pathogens make use of a single pathway, others transmit by multiple routes. So, for example, like a lot of sexually transmitted infections are only transmitted sexually. That's the only way to get them. Other pathogens like brucella, for example, has multiple pathways. It can be transmitted through any contact with any secretion of any kind from an animal or human, sexually, contact with aerosolized fecal matter, contact with saliva, eye tears, meat, milk, anything. So not all pathogens are the same. Actually, none of them are the same. They're all different in their own ways. But each one has a different implication for how we approach doing research. Airborne transmission is sort of the one we most think about. It's commonly studied as being sort of a group problem, syndromatic in schools, military, families. There's some experimental infection studies that look to try to assess how exactly influenza is transmitted. There's a lot that's really not known about how a person actually picks up influenza, what the exact conditions are. Um, so yeah, there's a few experimental studies out there, but it's mostly studying, when we have an outbreak in a group setting. Um, Outcomes, there are lab-based, lab conferred case definitions for different acute respiratory infections, influenza for one, bacterial definitely. But in general, clinicians are usually diagnosing based on various criteria, tallies of symptoms to get a severity score, and then they make a clinical diagnosis, just because that's the easiest thing to do. If you have to send a sample off to a lab, it's going to take time, it's going to cost money. So, and really, for influenza, I mean, treatment options are limited to begin with. Bacterial, of course, there's antibiotics, but viral disease is difficult. So I guess this brings up the question, what is an ILI? An influenza-like illness is a syndromic surveillance definition. Why? It's cheap, fast, and it's easy. You basically, a patient comes into a clinic, they have fever of 100 degrees or more, cough, sore throat, without a known cause other than influenza, and it is said that this person has an influenza-like illness. Lab confirmation data suggests that 60 to 80% of reported ILIs are actually caused by influenza, so it's good enough, really, for the purposes of clinical diagnosis and the purposes of epidemiology. A lot of us would say that that's just good enough, and it's cheap and easy. So on the CDC site, for example, you'll see a little bit about ILIs, and that's what this means. Fecal oral transmission. So this can be difficult because it's often difficult to capture the different comorbidities of human and host. Foodborne and waterborne diseases are a little bit different from one another. So that becomes difficult to tease out sometimes. Options for exposure, often you infer these from environmental sampling. You take water samples and test them for presence of pathogens. Contact tracing, you find a case and then you track them to a restaurant, and then you take a sample of the soup or whatever. And self-reported behaviors, like people will go to an area, for example, that has poor sanitation, and they come in with some sort of enteric disease, and gastrointestinal disease, and they report that they've been to a slum, Nairobi or wherever, and that's taken as an exposure. Options for outcome, clinical criteria are common, but diarrhea is kind of can be problematic, especially in a place where diarrhea is sort of a constant. For example, in Kenya, I mean, when I was working out there in the countryside, I mean, there's people that just have constant diarrhea. It's sort of normal. Not, asking somebody if they have diarrhea, they're like, no, I'm fine. This is just what I have. So we get, like, assessing severity can be difficult. Lab confirmed options obviously exist, especially for bacterial pathogens. Very easy to get a culture. Issue with community incidents and repeated events. So if water is poor in one particular area, people are constantly being infected, it becomes sort of difficult to assess. STIs, sexually transmitted infections. Many STIs are symptomatic in males and less so in females. Much of that is due to the morphology of males and females. This impacts transmission and outcomes. Obviously, if a male finds a sore, hopefully that person will not engage in behaviors, but for women, for anatomically female persons, it becomes a little bit difficult because the behavior might not change, and obviously this continues transmission. STIs are driven by human behavior. Obviously, pathogen doesn't induce us to do things. We just do them, which these things may be more or less rational in terms of sex workers, for example. This is obviously rational behavior. They're doing it for a living. And so that needs to be taken into account. HIV co-infections are a major risk factor because of the unique nature of HIV itself, which hijacks the immune system. Detection bias can be major. Private clinics versus public facilities. Obviously, there's a range of vigilance of detection there in some cases. Measurement of sexual behaviors. Who's asking? How are they asking? Why are they asking? Who are they asking it of? I mean, all these things are very, very difficult. I mean, people don't feel comfortable talking about their sexual behaviors in most cases, especially in areas where sex work is illegal. Sex workers are disincentivized to report their behaviors just because of legalities. There's specific designs for ID studies with STIs, partner studies. Person comes in, has a case of gonorrhea, go talk to the partner, can get information from there. So if someone's cheating on someone, I don't know. Network and peer referral studies. This is what we call snowball sampling or network sampling, where you find a case and then you assess all that person's contacts, and then you go out and investigate those contacts, and then potentially investigate their contacts. Vector-borne transmission is difficult because of seasonal dynamics and environmental variation have to be considered because you're dealing with a third organism, which has its own sort of population dynamics and own sort of behaviors and environmental sensitivities. Multiple populations may need to be sampled. This includes vectors and humans. Options for exposures, self-reporting. Obviously, if you say, you go to the doctor and you have a fever and chills and it's coming intermittently, and you say, I was in, rural Ghana or wherever, that could be part of how you get an indication of whether that person has malaria or not. Vector surveillance, this is one thing many friends of mine do. Go out and collect mosquitoes, count them, open them up, see if pathogens are in the gut, all different kinds of things. Options for outcomes can be easier because you can collect vectors and open their guts and figure out if there's pathogens in there or not. Total vectors infected for infectious can give you an idea of community risk and incidence or prevalence of human cases through either testing or just simple reporting. Okay, so that's it for this one. Super simple. I hope I have sound this time because last time I didn't. That was a real problem. So I'm going to try this again, upload it. If you have any questions, let me know.